Yes. Okay, so this is October 25th, and this is our SLIP meeting for the week. I'm Leanne. I'm the leader.
Lisa, I'm the scribe.
I'm Angela. I'm the timekeeper. It's officially 6:34 p.m.
And I'm Patricia. I'm the facilitator.
Okay, so we have been discussing for, I don't know, approximately 20 minutes before we did record, so just so that that's noted. So I think this week we're just going to kind of go over what we have and get ready for our mentor meeting, which is Wednesday.
Yes. Yes.
Okay, and then what time did you guys have, just to be sure?
I have 7 p.m. Pacific time.
Okay. That's what I had. I just wanted to make sure we were all on the same page while we're all here.
And Lisa, did you already send, I don't know if you set up the Google Hangout automatically then?
I can't remember if I already set it up, but I will double check that at the end of this and make sure that it's set up. I know that I sent her the invitation and she wrote back to us, and I think Leanne confirmed it. And I will double check and make sure that it is set up. If it isn't, I will set it up as soon as we're done tonight.
Okay.
Perfect. Okay, so Lisa, you were gonna to go over the budget. You were gonna screen share.
Yeah, I want to screen share. Tell me if you guys can't see it, because I'm kind of like Angela at this point. You're not sure what you can see and what you can't see when you do some of these things.
Mm-hmm.
So, let's see.
Did you guys see that thing where it looks like we can include some of our reimbursements?
Yeah, we were just
Let's see.
Yeah, we were talking about how going off of what she has on the budget, I'm going to include some of that in the criteria so that we can make sure our criteria matches the reimbursement for like the CMS requirements.
So can you guys see the Excel spreadsheet?
No.
While she's bringing that up, there was I looked at the rubric, and I don't know, did you see, Leanne, about they want a screening tool?
Yes. And so that's what I was going over with Lisa. I wanted to make sure that I was on the right track with it before I started putting it all together.
Okay.
And that's kind of where we got onto the CMS guidelines. So she's gonna email me a couple of the links that she has, because I was on that CMS website and holy smokes, I was like, I don't even know. Like, I couldn't figure out what was what, but she said that she's got some good information on that. And so based on what's on those links, I'm going to set up just a simple, here's the criteria. Yes, you have it. No, you don't. And
does it say specifically, I was looking up the gold standard, and it says there's mild, moderate, and then severe. I think we were talking about having either mild or moderate. I don't know which one you guys wanted, but then it even defines it. It says 50% less than the predicted 80% FEV.
Right.
Right. I had found, and I'll have to look at the article too, that it was with that gold standard. It was kind of confusing because part of it said 70 and then part of it said 80, and they both said that they were from that gold thing, and I was like, well,
I find that all the time, contradicting.
So I kind of thought I would wait to build the screening tool until we went over the budget, and then Lisa, because I want it to match the budget what she has for reimbursement. I want to make sure that I'm including that the patients have. And we talked about how she said that she included that there was going to be 10 new patients added a quarter. And so if we give these people this criteria and let's say that they meet, you know, all but 2, it doesn't automatically disqualify them, that they can see if they can get the proper documentation or whatever it is that they need, then they can be eligible for the next quarter.
Okay. So we're starting out with 10 each quarter?
Yeah, and she said for, what'd she say was the total?
I think she said 70, I think.
Well, that's what I'm thinking, but then I'm like, that isn't.
Yeah, I could have sworn she said 70. I could be wrong, but I could have sworn she said 70. And then when they say 10 a quarter, then I got confused. I was like, okay, 10 a quarter. What about 70?
She's trying to get that document up. And
yeah, once she puts it up, then we can see exactly what she's talking about. So, you know.
Right. So I kind of thought I'll wait and kind of see how this goes, and then I'll build it. And like I said, now that other class is complete, I definitely have the time to.
Woo, hallelujah.
Yes. Yes.
Oh, wait.
It's been a struggle, but we all got there.
Yes, Lord. Yes, Lord.
Yeah.
There she is. You got it, Lisa?
I every time I hit screen share and I click on to share it, it throws me out of the Hangout altogether.
Okay.
Well, I mean, I think that we could probably briefly go over it. I mean, verbally.
Okay.
I suppose it's better than not, I guess.
Okay. So I'll just start at the top. I have for operating revenue. What I did was I researched the Medicare CPD code, and most insurance companies will not pay you more than Medicare rates anyway. So for an initial patient assessment, we can be reimbursed $106 for 4 units or 1 hour. We can be only reimbursed if we have a registered nurse who is either, well, actually, let me take that back. We either have to have an advanced practice nurse, a clinical nurse specialist, a PA, or a physician in order to be able to bill. So I built our budget around an APN, and
Wait.
Hello? Huh?
You kind of cut out.
Oh, okay.
No, not you, Angela.
Oh. Oh, she's like frozen.
Yeah.
You're on mute, Angela.
Is Patricia, did we lose Patricia?
No,
Is that what you're saying?
No, I thought you were saying something, Angela, that you cut out.
Oh, no, I was on mute. I didn't say anything. But did you say that we had, in order for us to bill, it has to be a nurse practitioner? Is that for like the admission part of it, or
for any of it? For any telehealth, you have to be able to bill by CMS standards. The lowest that you can have participating is either a clinical nurse specialist, APN, physician assistant, or a physician. Otherwise,
wow. So I mean, all these nurses that work.
An RN is not billable.
So all these nurses that are working telehealth, they have to have a master's degree?
They may have to have a master's degree, or they're either not. They're one of 3 things is happening. They're either they're not billing for it. They have a physician who's doing some part of it somewhere, so that he's billing. The other person, somebody who's billable, is billing for it, and it just depends on what type of. God, I can't believe I know this much about this now. I guess I'm learning. So the
I'm sorry, I couldn't hear.
if you look at other items in the other types of telehealth that are out there, like cardiac or diabetic, you can bill for those. If you can bill for those with an RN or a social worker. You can bill for those on that type of a disease process. But with our disease process and the fact that we're doing a behavioral modification program, you have to have a clinical nurse specialist, APN, or higher.
That's interesting. That's frustrating because I mean, we can't have a nurse practitioner around every week, right?
Yes, we do. We have her budgeted.
Wow.
And I actually, the way that I've created this budget, we're actually at a $55,000 profit. So I put it in the Dropbox, so I want you guys to all look at it a little closer, but this is the way that I've worked it out. So patient initial, so what I did was us getting, adding 10 patients a quarter after the first quarter. The first quarter will be set up. We'll be setting up the program. After the first quarter, we'll add 10 patients. The second quarter, we'll add another 10, and another 10 the next quarter, on and on, until we have 70 patients in our program. So we can charge for the initial assessment for each one of these people. So for each one of these people, we can charge $106 for an hour worth of their initial assessment. So the APN will do 10 in April, and that's a cost or a revenue of $1,060 to us in April. And so I'm just going to kind of like look at the first part of it as we get going, and you'll be able to see it as it carries across as the year goes on, the 2 years go on. Then the next CPT code that we can bill for is patient intervention in a group, so in a group setting. So I figured that if we do something with them every week, so the first assessment would be, the first week would be their initial assessment in April, and then we would have 3 visits in April because they would meet with us 1 week every, the other 3 weeks of the month. So we can bill, on that CPT code, we can bill out $22 per person for the hour that we spend with them. So for $22 per person, we can, we would get $660 for the visits in April.
Per month?
For the month of April. Because you got to remember that increases too as we add people in. So it's exponential, some of this.
So are we saying, and just to clarify, so that, because I wanted to put some participation rules in the criteria. So is that like are we thinking like a one-on-one meeting once a week?
No. The first initial assessment would be one-on-one.
Okay.
For every person as they come into the program. Then we would do a group for everybody every week.
So like a group meeting, like kind of like what we're doing now?
Kind of thing, yeah.
Okay.
Oh, see, I misunderstood. I have that wrong, too. And I think that's part of, when I was reading our draft, I think we all have our different versions of, like, what our project is.
See, and that's why I wanted to go over this budget.
Yes.
If you guys don't agree with this budget, then our revenue is completely out of the window, and I've got to start from scratch.
Oh.
And I think as long as we do, I just was like on my part, I wanted to make sure that I had participation rules that, you know, if somebody isn't participating, then they're kind of just taking up a spot from someone who could be in the program. And so I just wanted to say like some sort of like you have to participate you know, however many times a week. So if we have a group meeting once a week that they have to attend those, you know, I'm assuming maybe we can have, obviously there's going to be more than one time in the week when they can do it. Otherwise that would be asking, you know, too much for everybody to be able to, you know, meet at the same time. But I didn't know if there should be other criteria, like if we were going to have, I know that we had talked about having like case managers and all that be a part of it, of things that they can even get on and listen to someone talk, even if it's not I didn't know if I should include that in the participation or if it's just that they have to meet with the group once a week.
The way that I built the budget, I'll just kind of give you a scenario of the way that I envisioned when I built the budget, because it was, if they want us to have a zero balance, to get $250,000 worth of revenue at $22 a person is really, really hard.
Yeah.
And so, and especially if you're only going to, if they told you not to have that many participants. I mean, if we did 1 million people, you know,
Right.
but they didn't want you to have that many participants, so it's like they really tied your hands. So this is the way that I looked at it, was that every quarter you would add 10 people for 7 quarters, okay? So so every quarter you would do an initial assessment on somebody. They would participate in the group sessions, and then every other month they would get, because we can bill for this too at a higher rate, is they would have an individual session with the nurse practitioner, just to check in with them and see how they're doing, so that it could be private away from the group.
Okay.
So if we did that,
So they have, okay, is that per week, the individual session?
no, every other month.
Individual session. Okay.
So if we did that, then as long as the APN is at every one of the meetings, so as long as she's logged in at every meeting, we can bill for her. We can invite the respiratory therapist, we can invite the social worker, and we can invite the dietitian at different intervals throughout the program. But the nurse practitioner always has to be online for us to be able to bill.
She can't be just the head person, or like the one that we report to?
No, she's the one. She's the one who is generating the revenue for us.
Okay.
Otherwise, you can't bill. So if she's if we're not going to have her be the one who's there doing the program, then all of that revenue will go, that we've got there will go out the door, and we will have to find our revenue someplace else. And right now, that revenue is running about, let's see, 72, 100. It's running about $150,000 in revenue right now.
And I don't think that having her on board for all of those different meetings is probably too much to ask. I mean, I think that we could, I mean, I don't know, I'm not, you know, really all that great on budgets or whatever, but I mean, like, as the program grows, if it is going to grow beyond, you know, 70, like, we could incorporate an additional nurse practitioner, like, you know, maybe, I don't know if we have to say that in there, that
I will tell you guys, is I calculate the hours out, and I look at it just from the programs I run. This isn't a full-time job. This isn't even a half-time job.
Oh, really?
Well, no, because you're talking about a nurse practitioner being available one time so for 10 hours a month, and you know, okay, let's just look at April. So she's got to be available for 10 hours to assess these patients, for 10 patients, right? And then she's got to be available another 3 hours to run the group session. We need her for 13 hours a month.
Well, and I think that we need to be realistic and say that we need to have more than one group meeting time a week, because, you know, especially throughout this program, we've all discovered how hard it is to get us all at the same time once a week.
Right.
We're still only talking another 3 hours a week.
Right, right. So even if we did have her do 2 or 3 sessions in a week, we could, I mean, that's an easy, still under a full-time job.
Yeah, see, I guess I was thinking that it was more individual, like more like she met with each patient, like met each patient once a week. And like I think I put it underneath my technology part. So that's why if we're gonna change it, I can change it, but I just want to make it understand, because part of the technology part was fit tracker and to bring up their medical stuff. So I don't know if we can really do that in a group setting, right? So they have to do it on an individual basis.
Is it realistic for her to meet with 70 patients a month when we get to the seventh quarter?
Well, it would take us what, 3 years to get to 70 patients?
No, it takes us 2.
Because each quarter, there's 4 quarters in a year, right?
Right.
You're only taking on 10, so that's 40.
About a year and a half.
You're taking on another 40. That's 80. But the first quarter we didn't take on any, so that makes us at 70.
Oh, we didn't take any on in the first quarter?
The first quarter
No.
we didn't.
Okay.
I mean, I'm just saying, like, for the budget. I mean, not for the budget, but for like the timeline. I don't know. I'd have to, sit down and look at is it possible for one person to individually see 70 patients a month?
If you're talking an hour, let me just tell you, in the clinic they see way more than that. So in a day, in a clinic they will schedule them to see 35, 40 patients a day. So to get an hour with a practitioner is huge, absolutely huge. And so if you're talking about 70 people at the end of, so your last final month where we have 70 people, right? Mm-hmm. And you're working her part-time. So you've got a 40-hour work week, so you're working her part-time, so she's got 80 hours, right?
Mm-hmm.
So and you have 10 hours left over for her to still be able to do her group sessions.
Mm-hmm. So then these are established patients already.
Correct.
These patients are already established within that group. So if she's already know these patients, she already know the criteria. They've already met the criteria. She's already met with them. So it's like once you assess them, it's like for us when we go on the floor. You've already assessed your patient. You already know if it's just the same patient that you're seeing every time you come on the floor. You already know what's going on with that patient. So you just kind of going from that point and moving on to the next point. That's how I see it.
Yeah, kind of like just maintenance.
Yes, yes.
So if we did do, like Angela was saying, and we did have it to where she met individually with each person once a week?
No. What I've got is, because then if you're talking once a week, then you are talking about you don't have enough time and you don't have enough man hours. So like I said, the way that the budget is set up is, and if you guys look at it, it's in the Dropbox. I'll try and share it again, but I'm afraid I'm going to get kicked off.
Did you submit it already, then?
Well, you put it in the Dropbox, in the working Dropbox. Everything's in the working, or it should be.
Oh, okay, the forum. Okay.
So if you bring 10 in every quarter, you have a group meeting with them every week, and then every other month they get a reassessment or an individual intervention with the provider by themselves. Then they've been seen that they've got four group settings every week. Then you've got them seeing the nurse practitioner, are seeing the nurse practitioner every other month, and then a reassessment every quarter. They're getting plenty of face time with that nurse practitioner, plus they're getting the group and the support and the education. And as a matter of fact, I even thought that doing every other month for a reassessment and the patient intervention, or the individual one, I thought, God, I wonder if CMS will even pay that often. But I don't know. It didn't say in there how often they would pay for these services. So let's go through the rest of the budgets, because there might be other issues you guys have besides this part. So that works to bring.
Lisa, I don't have any issues. I think I'm just a little bit confused on what the intervention is, because I feel like it's a couple different routes that we're all talking about, and I kind of think we all need to come up with what it is going to be, and then that way we're not duplicating or having to go back and fix something. You know what I mean?
Right. I agree.
Okay.
So when we do, so I guess my idea of what the intervention was is that they do get this FaceTime to discuss any issues or whatever, and then keep up their, this is how I'm progressing, this is what I'm doing, they're checking in, I guess.
That's what I thought too. I thought it was more like a self-paced, internet-based program. So whenever they felt like getting on and seeing the video from a pulmonologist, or whenever they felt like seeing a yoga instructor, at wherever they were at, they can get a mobile app and look at it, or if they wanted to get on the computer and look at it. But it was more individualized because it was meeting their timeline, whatever their timeline is. If they couldn't sleep that night and they want to figure out how to, work on, how to handle sleep insomnia, they would be able to get on our website and see the video from 3 months ago about sleep hygiene.
Yeah, I had that in mind as well, that we had this Facebook page that they could utilize, but what I understood was that there was going to be these group sessions, and you can't bill for getting onto a website.
I think we can do both, though.
I agree. I thought that, because I've got Facebook on here, if I can just go through the rest of the budget, I could show you guys where Facebook is incorporated, because I understood it the way that Angela said, that my understanding was there was going to be group sessions along with this Facebook app or whatever it was that gave you information, that there were other places you could click on, that we would have advertisers that were going to be supporting the Facebook page, that there were going to be sponsors that you could maybe, like if you had, I don't know, like if you were doing diabetes, that you would have the Lantus people have a place where you could click and go to their link with the study and stuff like that. That was what I thought. But the group part was, I believe that we were having group meetings, and that was why I built that budget. And for me, when they decided that we had to be budget neutral or profitable, they changed the whole game. Because if it was just that we were if they were giving us $250,000 to create a program, we didn't need to have, we could have done just an app and something like that. But then when they wanted us to start getting reimbursement, they changed the whole face of everything. And if we were the diabetic group, we could do anything we wanted. We could stand on our hands and sing Kumbaya and get reimbursed for it.
Right.
And we could have the janitor teaching the class.
Yeah.
Because it's this, you can't do anything. I was really disappointed when I saw them come across with those tips for success on the finance, because I had this all plotted out in my head, and when they changed the whole finance thing, I was like, oh man, now they want us to be zero or profitable, and it was a game changer. I think that, so let me finish going through the budget, and then let's talk about how we want to change things or how we want to do things. So that's what I had for the CPT codes for the reimbursement. And then for advertising, this is still revenue that I'm on, is advertising I did for Facebook. So, and Angela, it seems to me like you and Leanne might be more in tune to social media than I am, and maybe even you too, Patricia. But when I Googled it and looked to see how much it costs for advertising on Facebook, there really wasn't anybody who came out and said, if you want to put advertising on our page, that we're going to charge you something. So what I thought is that we would charge them $3,000.
Wait, I'm sorry. What was that? You broke up on me. I'm sorry.
I thought that we would charge them $3,000 a year to be able to participate, to be able to be on our advertising.
Yeah, you can. I'm not sure exactly how much they get reimbursed, or like how much they pay to advertise on the Facebook pages. But I mean, even on our website and on our web page, they could be on there too.
I thought $3,000 was a reasonable amount for somebody to pay. I don't know.
Per year?
Per year.
Yeah, that's. I mean, I don't know how much it goes, but it sounds like that would be totally reasonable.
For an expense for us, it's going to be $365. It's $700 per. It's $1 for every advertiser that we put on our Facebook page. Mm-hmm. $1 a day, and you're supposed to budget for $2 a day. So we have to pay that part to be able to put the advertiser on our Facebook. So I felt like if we're paying $700 for you to be on our Facebook, then you're going to pay us $3,000 for that privilege.
Okay.
Is that not reasonable? So then the Fitbit sponsorship, and I thought, you know,
I'm sorry, you broke up on me. I'm thinking.
The Fitbit, you know, it has like a little face plate that you can buy for it. So I thought that we would jack up the price a little bit and have fit like a little plate put over it, or have the band designed or something screen printed on the band for sponsorship for each band. So say that, I don't know, 24-Hour Fitness or whatever, some gym wanted to be the fitness band sponsorship, that they would have to pay us $500 per band to be on the band. Because the bands cost about $110 a piece.
Yeah, and then I guess my question was, and apparently a lot of my coworkers, they're handing them out like candy to insurance because they go do some pre-screening fit. They're getting it for free. These track fitters. So is there a way we can get those? I don't know if you stayed in the budget, but are we getting those reimbursed?
Well, we're not getting them reimbursed. We're making the people who are sponsoring them pay for them. So whoever's advertising is on it is the one who's paying for it.
Okay.
Because I didn't see anything where they were reimbursable. So.
I'm sorry?
I didn't see it anywhere where it was reimbursable. So then the other thing I did was a corporate sponsorship, so that we could have, like, maybe on our Facebook we could say that we have 2 corporate sponsors and we could put their logo along with us on our Facebook or whatever. And I was going to charge them $10,000 a year to put their logo on our Facebook.
Yeah. Then
getting into the and that revenue was generated $305,690 over 2 years. Now our expenses. So the APN, if we worked the APN half-time, and because we're working her half-time, we didn't give her any benefits, and we paid her $50 an hour. We wouldn't work her for the first 2 months because we would be developing the program and we wouldn't need her for that part of it. And then I put in a program coordinator, RN. I think that was what you guys called it, a program coordinator or something like that. So I put a program coordinator, RN, at $30 an hour. And again, I did her half-time, so we didn't have to pay her benefits. So that was 1,040 hours a year. And then I did the respiratory therapist times 20 hours a month, because they wouldn't have to be there the whole time. They would just have to help with some development and then to be available for some of the sessions. And I put them at $25 an hour times 20 hours a month. And then our IT professional, I put them at $35 a hour, and I did them 80 hours for the first couple months for the first 3 months for development. So that was like 2 weeks, 2 totally dedicated weeks where they worked on nothing but our project for the first 3 months. And then after that, I put them down to that we only needed them like 5 hours a month, because I figured we would just need them on call while we were doing video, you know, stuff like that. Go ahead.
I'm sorry. Can we use our existing website people?
I don't know what your hospitals are like, but our hospital really, I mean, I would think that this would be one of our IT people, but I think that you still have to pay for them. You still have to, you know, budget for hours for them.
I think so too.
Yeah, because they won't. I know that when I do projects, and if I can get just a little bit of time out of somebody if I've got a tiny project I'm working on, but if I start using them routinely, then their boss starts saying to me, "Who's paying for your hours now?" And you know, they want to know that they're getting money back somehow for it.
Okay.
For employee benefits, I put none for this project because we're working either anybody partially or part-time. For supplies, I put the Fitbit at $110 a piece. You can get them for $89 at the cheapest, with the kind that we need. You can get them for $89. but I built in the other amount so that we could get the advertising on them. Educational materials, I didn't even know what the educational materials might be. I didn't know whether they'd be DVDs, books, I didn't know, but I put $100 per participant. So we can spend $100 flat for every participant, whatever doodads we want to provide them. Office supplies, I did $150 a month because we're obviously going to have paper and other things we're going to need. For professional services, I did a dietitian at $30 an hour for 1.5 hours a month because I figured that they would be here, that we wouldn't use them every month and that we wouldn't use them every session. So I did an hour and a half a month because we could have them speaking for 30 minutes in 3 of the sessions. That, you know, like Leanne said, that that we would need to divide up and have more than just one session, so we could have them speak for 30 minutes with the, you know, APN leading the discussion or whatever. Same thing with the social worker. I did a social worker at $35 an hour times 1.5 hours a month. And then I did a physical therapist. I didn't know if we wanted a physical therapist or somebody else doing something, but the physical therapist I put in at $45 an hour for 1.5 hours a month. And then for professional services, I did IT professional consulting because I figured, remember how we talked about how the patients might have, like, need help setting it up at home? So I figured, I was thinking that maybe we had an IT professional who would have to go out to their home and make sure, if, like, say that somebody had a problem getting the Wi-Fi or whatever, that they would have to go and help them set it up or help them learn how to use to get in or whatever. So I did $50 per patient and just figured that every patient would have the opportunity to have somebody at their house to give a consult. Facebook advertising, I did $30 or 30 because remember I said that it was $1 a day, and I figured we could maybe, or it was cheap. It ended up actually being $2 a day for Facebook advertising that we have to pay Facebook, and times 365 days. So I figured we might end up with like 15 advertisers. So I did $30 times 365 for that expense.
So and we would pay. I'm sorry. Just we would pay $30.
Yeah, we have to pay Facebook to put an advertiser on our Facebook account.
I know. I run a social networking site on Facebook. It's $5 a day.
Oh, really? Because what I read was that it was $1 a day, and but then you were limited. You had a limited number of hits that you could take. And then they said to budget for $2 a day, so that if you went over that budget, and your $5 a day is probably unlimited hits.
Well, it kind of restricts it. It's kind of like it gives you like how many people will actually see the site.
Yeah, because I was on Facebook looking at how much it was going to cost, and it leads you in saying it's $1 a day, and then it says, but you better budget for 2. So I budgeted for $2 a day. Do you want me to take it to 5? I mean, I can, but I mean, it says on the Facebook. We can use it as a reference.
So we're advertising to who?
For us to put the advertiser on there. So these people who are paying us $3,000, so say that it's Jamba Juice, I think somebody said one time. So say it's Jamba Juice that we're allowing to put on the put their ad on our Facebook page. We have to pay to put them on there, which is the $2 a day, but we're going to make them pay us $3,000 for that right to do that.
Well, why wouldn't Jamba Juice just advertise on their own then? Why they got to advertise on our page? What I'm saying is, generally what happens is when you're advertising on Facebook, like I advertise all the time for our social networking site, and it's just to get more people to follow our page. So that means we would have more patients. Does that make sense?
We're not looking for more patients. We're looking for it to generate us revenue for the advertisers.
Right, but what I'm saying is the way that Facebook is set up, when we advertise, we're looking for new people to like our page. Does that make sense?
Mm-hmm.
Yes, but
we're looking for more followers. So like when I set out $5 per day, I generally get like 30 or 50 more likes to follow my page. I get that many more followers.
But we're not going to be the ones who are advertising. We're going to be allowing people to advertise on our page.
Right, but what I'm saying is, I understand what you're saying. We're gonna let Jamba Juice advertise on our page, but who they're advertising to is our patients. We have 70. And what I'm saying is, when we are advertising, we're advertising to other Facebook followers to follow us. So what I'm saying is, Jamba Juice is not going to want to advertise on our Facebook page for us to advertise them. They're going to have their own page.
So when you suggested that we generate revenue from advertising on our Facebook, what did you mean then?
Because what I was thinking is we'd have more patients.
Oh, because I think that it was pretty clear from when we spoke to our instructor that we weren't going to have very many patients. I mean,
right. At the very beginning, we talked about Facebook. I think we all I talked about Facebook. But at the same time, I was thinking we'd have more patients when you advertise. Like, for example, I have 4,000 followers. So I can advertise to my 4,000 followers for a specific item, like nursing item, that would be appealing to my followers. They'll see it on my page. Does that make sense?
It does. So you're going to change if we delete this, we'll change the budget for a loss of...
Well, no, I'm not saying to delete it. What I'm saying is, if we are going to have a small number of patients, advertising on, like, us getting advertisers on Facebook is not going to be relevant. We'd have to actually put it on a web page, maybe, or like the DHR website.
If we're not going to use it, we need to take it out of the budget. That's my point. Because right now I'm just trying to get the budget done. Because that's my job right now, is to get the budget done. So I need to get the input from you guys to be able to get the budget done. So that'll be a net loss of $19,000 of revenue. And then we need to look at, so that's the Facebook advertising there. And if we're going to delete it, we just need to know that if that isn't how it works, we've got to make up $19,050 somewhere. The next one is the capital equipment purchases, and we have the computers, and I put in for $2,100 for computers, $7,000 for video equipment to be able to do like Skype and the TVs, or the Skype camera and the connection, or whatever we're using. Airtime and Wi-Fi equipment, because the computer department will need us to have a server and to be able to run it off of there, and that'll be $7,000. And then I put in another $2,595 for Facebook and web design, which we can change into just web design or some other part if we aren't going to be using the Facebook. So that's the budget. So tell me where we need to change it.
I think, okay, let me just put this so that I can understand. So we're going to have an app that our patients can access, which is where they can do these group meetings, so that it's kind of like this, that they can also access all of the videos, or, you know, like Angela was saying before, like if they want to learn about yoga, all that stuff's on there. So that is going to be our app. So do we need Facebook?
Yeah, so I think originally, like when we first met, I had said something about Facebook, because it was a way to, Facebook is so cheap to set up, it's virtually free. And you can put a number of different things on there. You can also, in my mind, you could set up events, which is completely free. It's not something we would have to pay for. So, for example, I host an event where all my followers can join, and it's virtual, for example. So, and it's free. It's free to set up. There's no cost to it. And then I know for COPDers, it would be like, in my mind, I was thinking it would be an event like, hey, the YMCA is having a group hike for that particular week, or hey, COPDers that are following. But 70 people, now that the game has changed,
Mm-hmm.
generally would not be good for a Facebook page, because I mean a Facebook page generally has thousands and thousands of followers. So
just take
that
all of
loses
that
our-
information and put it on the app. Like we could have like an events tab, right?
Yeah, what I was thinking is, because we are narrowing our numbers, we would have to have more like a website. That website that can go mobile and virtually have an app too, but it'd go to the same place, just a mobile mobile.
Can't we have both? Because I see what you're saying about the Facebook and it being limited and the numbers, and I understand all of that. But why couldn't our Facebook be open for anybody? You wouldn't have to be a participant to be on the Facebook. You could still get the education. You could still join our group and be learning. That wouldn't hurt us or the hospital or anything. We could generate money from it. And then we use this web design money to design this mobile app that we're talking about. How does that sound? And we can move the money around.
It would definitely work, but we'd have to propose that we are not just working, I mean, and that might be where the community part comes in. We're not just looking at the people that we currently have here at DHRA, but we're looking at, like, because with Facebook, you can't control it. So what I mean by that is, you think you're going to start in Arizona, and you end up being national within, a few days. So, I mean, you don't have control, because somebody in New York sees it and they like it, they're going to follow it. Do you see what I'm saying? So you really can't.
But they can follow it, but we can control it so that they can't post if we don't want them to.
Well, you can block them, but I'm saying is,
no, you can have rights to your Facebook page where that's how our hospital is we've got rights to our Facebook page where anybody who comes in, say that I post something and I want to say something bad about the hospital, the marketing people get it before it gets posted, and they either get to reject it or allow it to go through.
Right, but what I'm saying is, though, the followers, if they want to follow it, generally it's not something that people block. The page doesn't usually, like, if you follow, what's your hospital's name?
University Medical Center, and anybody can follow it. You just can't post freely to it.
Right. Yeah, that's the same with my page. People can't just post, but what I'm saying is those followers can be anywhere. Is what I'm saying. You can't really control it, and that's what I'm saying. You can't.
We could be getting people from Alaska looking at our Facebook page.
Right. Is what I'm saying. So we can't, like, which I'm okay with. I think it makes more sense, and we would hit more people, and I think we make more of a difference. But I don't know if we would, as far as reimbursement and how that stuff would work out,
Well, it doesn't. The Facebook doesn't come into reimbursement at all. The only reimbursement we're going to get, the only way we're going to get any reimbursement from CMS or insurance companies or anything else, the only CPT codes that are out there to cover this for COPD are if we have an APN actually doing tele meetings with patients.
So there's no reimbursement for a patient enrolling in any type of rehabilitation program for COPDers?
There are, but not for COPD.
Not with what?
Not for COPD. If we were doing smoking cessation, if we were diabetic, if we were doing cervical cancer, or what was the other one that I was like, dang, we don't have any of these. There's one more. I think end-stage renal disease. Let me see if I can pull it.
The heart failure?
What if we took out the the revenue that we would get from the advertising on Facebook? Like, if we just had a Facebook page where anybody can follow it, anybody can receive free education. I mean, obviously they're not going to get the one-on-one group meeting and, all of that, but they can still, get the information that we are putting out there for COPD patients.
But why can't we take on those patients? That, like, say if they wanted to enroll and we charged, can we take on those patients? Can the nurse practitioner do a virtual assessment? I mean, are we expecting them to go down and assess each and every patient?
It's a virtual. It's a behavioral. Because this is behavioral modification type of thing. Yeah, no, she doesn't. It doesn't have to be our patient. You're right, Angela. I think that the Facebook is just kind of extraneous to what we're kind of doing, like you said, to maybe do some recruitment, maybe get some advertising out there to be able to say in our plan that we're marketable. That can be our marketing campaign. And I think that Angela is right with big part is developing this mobile app that allows the people to be, because you know, if you were stuck in your car tonight when the call came in, you could have pulled over to the side of the road and done the call on your cell phone. So
Right.
Google Hangouts. So I think Angela is right that that's where we put maybe I move some money around and put more money into this app development so that they can sign on wherever they are to be involved in the group.
Yeah. And the thing is, the web page, like, we could still do advertising on there too. I just want you guys to understand the way that Facebook works. Like, you can't just advertise for advertise. You know what I mean? Like, the advertisers want to come to you. Why do they want to come to you? Because you have a large audience.
So do we take the Facebook part out of it, and instead of saying Facebook, how did I put it on here? Facebook advertising. Do we put web page? Do we just do strictly a web page instead of Facebook?
You could do a web page. I mean, so you're saying not do Facebook at all, or you do want to do Facebook?
I don't care what we do. But I'm just.
I don't care either. I think we all just need to come up with
What if, can we have somewhere in there that in the future, once we learn that this is profitable, that it's good, and that it's working for all of these people, that we eventually could build a Facebook page and outsource it to a national thing, because it is all mobile. So that we're not having to do it right now, but we do hope to do it in the future. This is just our start.
So for me right now, what I've got on is I've got my accountant hat on.
Right.
And that's why I'm just kind of throwing all of this back at you guys, because I'm kind of letting you guys think about how you want to develop and let your creative juices flowing, bringing you back to the reality of the dollars. So the only thing that I did the Facebook for was advertising, purely to charge people to advertise and to pay us money for advertising. And that brings us in, over the 2-year period, it brings us in $75,000. That's a huge chunk. That's a huge chunk of money for us. So we can do website advertising instead of Facebook advertising and just call it the same thing, as far as I'm concerned.
Right. I think that maybe is more of a direction that we should head, and then, you know, I think the Facebook thing is an amazing idea, just maybe not in the beginning. We might be getting in over our head.
Yeah. Yeah. Is there? I don't know. We could just take the Facebook part out if you want, and just do the website to make it simple. Sorry for the confusion, but it's just the way that the Facebook runs. And then when she said we have to really limit who we're accepting, I mean, which makes sense because it's only $250,000. But I guess for me, I was thinking $250,000, you could turn around and make that into more money.
Right.
Yeah, and for me, you know, I didn't even really think about the way it worked. I just looking at.
I would have had no idea.
Me either.
Okay, so I'm changing it to advertising on our website then.
Okay.
I think that makes it the most simple.
Mm-hmm.
And I'm okay with that, because
Me
things
too.
are we have enough complicated things in our lives right now.
Simple is better.
And the money that we're charging for, or that we're paying out for what I thought we were paying out for Facebook advertising, which is $21,000, I'm going to put web design and maintenance. How does that?
Yeah. I think.
Yeah, and I'd like to talk to her tomorrow about, like, because I know she said we could use the DHRA resources, right?
Right.
But I know you guys got dinged before, but we need to figure out, like,
What does she mean by that?
But how much better is this if the only resources we're using is an office space? Because then we're not costing the hospital anything, and we're making them $55,000.
Right.
yeah. The thing with internet, and you don't need it's not a whole lot of overhead usually.
Right.
But you still need an office where you put your computers, you know? Which can be very small, but that can be the in-kind donation that that DHR gives us.
Okay, so just to make sure I understand correctly, we are doing the NP. They're going to assess them at the admission, right?
Run the group.
Wait, I just want to make sure I go through, that way I can make sure I understand. So the NP is going to assess them at the assess them for the admission of the program, correct?
Correct.
Okay. Is that going to be done virtually or in person?
It can be done virtually, if you can believe that.
Because they will already have, for the criteria in order to be in the program, they already have the proper documentation from their physician stating this is their stage of COPD. Like, the NP doesn't have to determine that.
No, it should be like it sounds like it's more like a referral based. Like,
Yes.
you know, I don't know if you can incorporate in there is in the budget is how much money are we going to save DHRA from not having these people readmitted?
Right.
Does that count? Do we get that money back?
The problem is that you can't determine your readmission rate until, you know, that's a retrospective view. So I'll read you what the CPT code says. It's 96-150, and it says the initial assessment of the patient to determine the biological, psychological, and social factors affecting the patient's physical health and any treatment problems.
Okay. All right, and then these group sessions.
So then
the group sessions, do we have to, I mean, I don't want to be negative, but do we have to do group sessions, or can we refer them to other group sessions that are in their local area?
If you don't do the group sessions, you will lose.
Oh, because you're getting reimbursed for it. Is that what you're saying?
Yes. You will lose, get this, take a deep breath, $72,000. Those group sessions at once a week for an hour can generate us $72,000.
So the group sessions, can we just make that instead of with the end? I mean, do you think it should be? Is it going to be changing out then every week for whoever is on deck? Like, are we going to change it to?
They just have to be there.
So he is actually, like, let's say the leader of the group session. But that week we're going to say, hey, but today with us we also have a dietitian. So our focus this week is going to be on diet.
Yeah.
But the NP is present, so we get reimbursed.
So here is the CPT code for that and what it says about 96153. The intervention service provided to a group. An example is a smoking cessation program that includes educational information, cognitive behavioral treatment, and social support. Group sessions typically last for 90 minutes, involve 8 to 10 patients. So the ability to the group sessions are charged out in hour time increments, and that was I used the financial money that I used as revenue was based on 1 hour of intervention, not 90 minutes.
So does it? I mean, I know you said group sessions such as smoking cessation. Does it have any? Is it defined any other way, or is it just any type of group session?
Not in this particular document. There's millions of documents out there that talk about what you can.
What defines a group session?
So it says, until now, how these services differ from psychotherapy. Until now, almost all intervention codes used by psychologists involved psychotherapy and required a mental health diagnosis, such as under the DSM-IV. In contrast, health and behavior assessment intervention services focus on patients whose primary diagnosis is physical in nature. The codes capture services addressing a wide range of physical health issues, such as patient adherence to medical treatment, symptom management, health-promoting behaviors, health-related risk-taking behaviors, and overall adjustment to physical illness. In almost all of these cases, a physician will already have diagnosed the patient's physical health problem. Physical health diagnoses are typically represented by ICD-9 codes, which are now 10 codes.
So yeah, health promotion, it looks like it meets all those.
Yes.
When providing outpatient care to Medicare beneficiary services for these patients will be reimbursed at a higher rate than psychotherapy because under current federal regulations, the outpatient mental health treatment limitation does not apply to these new services provided to patients with the mental, psychoneurotic, or personality disorder as identified by ICD-9 code.
But that doesn't define to us, right? Because we're not going to do just like.
And I'm trying to find where there's another one that says who can bill, and it might not be in this paper. It's in another one.
Not to get totally off subject, but Angela, do you know what our time is at?
7:34. We're in an hour.
Okay, I just wanted to keep on track. And how long? Was there a time limit on these? I don't even remember.
No, but I know you got to get to your. You've got to get.
A lot to do.
Well, we got to submit this draft, right, by tonight?
Right. I just wanted to make sure we were on the same time. My paper is done, so.
Well, and you guys all put your information in the thing, right? What I did was for mine on the Hangouts was I put to see the spreadsheet, because until we have a good solid plan, and I mean, like even now I would have written in the Facebook and I'd have done all this stuff about Facebook, and then I would have gone, oh, never mind.
Sorry.
No, that's why we're doing this. Is because
right. I think that's exactly the point of the meeting. And
exactly. No, I'm glad you.
I envisioned it to be more bigger than it was.
Right.
But I think we all did, and I envisioned somebody was giving us a gift of $250,000 too. And when she said that we had to come up and make it budget neutral, I was like, oh my God. And then when I was able to really put in the things that I really thought we needed and make a profit, I thought, wow, that's even better. If we really could bill it out this way and do it this way, we could be all right.
Right.
Yeah. I guess I was hoping that she would. I mean, I know $250,000 is a gift, but we're also preventing them from coming back.
Right.
So that has to be factored in somewhere.
The hard part with that is that you can't say for sure that Lisa Pacheco is the one who didn't come back. All you can say is that 2 years down the road after we started this program, that 2 years down the road, our readmission rate for COPD was decreased by 10%. And then as the bean counters are going to look at it, they're going to go, well, was it really this program? Or maybe somebody else started another program? Or maybe it was the smoking cessation that we did? Or maybe it was because we started handing out Chantix patches to everybody. Everybody's going to be saying it was my program, it was me, I did it, and you never know. So, yeah, can you say that that's your goal? Yeah, but you can't quantify it in dollars. It's really hard to quantify it in dollars.
Okay.
So, Lisa, do you feel like you got what you needed from us as for the budget?
I do. I think I will focus on this mobile app that Angela's talking about, because I like that idea. I'm not I guess I'm getting more and more technology savvy, but it just hasn't been my thing. And I have 12 people on my Facebook. I don't have 4,000. So it's an eye opener to me. But I like mobile apps. I've got a couple of different things that I depend on that I use. Mm-hmm. And I know that when we did the Google Hangouts, there was a couple times where I was having computer problems, and I did the whole hour on my cell phone, with it up to my face like this, talking to everybody, and nobody even could tell that I was on my cell phone.
Mm-hmm. Right. Yeah. Yeah.
So I think that I really like the idea, and I think if I take that money and put it into web design and mobile app design, I think it's a better program already.
Okay.
So they're doing an assessment. They're meeting every quarter with the NP, right?
Mm-hmm.
And then the group session once a week.
Correct.
Okay.
So the other question I had is about the hourly rates for the employees. Do those all sound reasonable to you? So I got $50 an hour for an APN. I don't know what you guys pay yours, but I paid anywhere from $45 to $57. program coordinator, $30 an hour. Did that sound for an RN with a bachelor's degree? Did that sound reasonable?
Quick
Yes.
question, Lisa, not to throw a monkey in the wrench, but is there any way that the NP can do the same thing as what the RN coordinator is doing?
And make her full-time?
I don't know. If
We would
that
have
one should be full-time, or if that makes her a little bit less than full-time, or I don't know, but I'm just curious.
If we used just the APN instead of doing a program coordinator as well, then we're going to be paying, because the program coordinators, I envision, is the person who's kind of collecting the data and coordinating the patients and getting them on track and making sure that the IT person gets there and the respiratory person is scheduled for the day that they're supposed to be there and stuff like that. That's what I see them doing, and I wouldn't want to pay anybody $50 an hour to do that. Plus,
Okay, that makes sense.
if I make the APN $50, if I make her a full-time employee, if I boost her up any more in her hours, I'm gonna have to start paying her benefits, and the benefits are close.
Okay.
Benefits are usually benefits just tank your budget. That's why everybody wants to pay part-time people nowadays. And then
Until
the
the Obamacare.
respiratory therapist, like $25 an hour. Does that sound reasonable?
Mm-hmm.
And then the IT person, like $35 an hour? I don't know how much an IT person makes. I know ours make a lot. And I know I pay them anything.
Right. I think that all sounds reasonable. I mean, I think whatever you guys think is probably more realistic for that area. In South Dakota, we're a little behind.
Arizona's really behind.
Low, too. You're not paying $2.87 a gallon of gas, you know?
Well, they just had like a study out that said that South Dakota was the lowest nurse-paid state in America.
Seriously?
Where do you start graduate nurses out at?
What?
Where do you start graduate nurses out at?
I think at my hospital, an ADN and a BSN don't make a different amount of money. Like
Me neither.
22.
Really? Wow.
Yeah.
Oh, wow.
Yeah.
Yeah, I was making 22 when I came here. When I came here 20 years ago, and I left New Mexico. I came here making 22 as a staff nurse, and I left New Mexico getting paid 17 as a charge nurse, like as assistant clinical manager. So yeah, it just depends on where you live, you know.
Right. That's why I think, I mean, whatever you guys think for those wages, I think is totally fine because you're probably more in the realistic world than my world.
What do you and Angela think about the wages? Do they sound reasonable?
Yeah.
Okay. All right. Well, that was what I needed, and I will write the narrative then for it. I'll do a narrative also in the Excel spreadsheet, and then I'll write a narrative to go in the
Okay.
Sorry, one more thing, Lisa. The education. We had a budget for educating patients.
education materials, $100 per participant, whatever you want to buy. I don't know what you want to buy. You can buy those local things.
Okay.
Yeah, I figured $100 a participant, that's a pretty good budget to be able to spend on somebody.
Right.
Especially for education.
Yeah,
Yes.
I mean, you can do whatever you want with it, so get creative with it, you know?
Right. So, Patricia, do you have questions on your part?
So I guess I have to change, since it's going to be an APN. I saw your note, Lisa, to change, put the APN within the plan for the care of delivery.
Uh-huh.
So I have to take out the case manager, I guess, and put the APN.
No, you'll use an APN, and then the case manager, just why don't you change it to a program coordinator instead?
Okay, because I have a referral coordinator, which I can make as the care coordinator.
Okay.
I'll just take the case manager out, and then I'll just add, because you said dietitian, social worker, and physical therapist.
dietitian, social worker, and physical therapist will be professional services we paid for.
Okay, I put them in as part of the interprofessional team.
Okay.
Okay.
And don't forget the IT consultant too.
Huh?
We'll have an IT professional, but we'll also have the consultant to do like the web design. There'll be two different people, you know.
Okay.
We'll have
So
like one person who has to do things for us at the hospital, and then we'll have this consultant person that will have to do the rest of the stuff.
The main thing is the HIPAA.
Huh?
The main thing with the IT person, I feel, is like the HIPAA. You need to make sure it doesn't get hacked into.
Everything's secure.
They've got to be protected.
Right. Right.
Where
So-
the other person is just designing our website and putting, you know, making it appealing, making the radio, you know, boxes click where they're supposed to, that kind of stuff.
Yeah. Yeah. I had the IT technology staff in there, but I'll put the consultant within the interprofessional team involvement. So I just need to add those things. I mean, I don't know if you guys looked at it or not, but I just need to add that part to what I have. So
So tomorrow, you guys want me to pull it off and put it in a Word document again and put it or put it into the Word document that's already on there or whatever?
I mean, we can. I feel like, do you feel like we all need to go through here, though, and really, like, proofread it? Because I know, like, mine has nothing to what our plan is like. I didn't talk about the group. I didn't talk about that.
When do
I
we
feel like it's all over the place.
huh?
Dropped into the Dropbox by tomorrow for her to have it, because we meet with her on, what, the 28th, and she wants it 2 days ahead of time. So it has to be there by
Well, could we do
tomorrow.
it tomorrow evening? I mean, I guess I don't really know.
I can't.
I mean,
You guys
just
can. You guys can.
just to have it submitted, not to meet.
Oh. So do we need to go over it tonight, or just everybody just?
I
What do
think
we do?
everybody just needs to tweak their part for what we've discussed so that it flows, because like you said, I think we all kind of had a different idea. Now we're more on the same page so that everybody can get everything in line. So Lisa, if you were to submit it tomorrow evening by like 5, 8, I don't know, whatever.
I won't even be home until after like 6:30 or 7. So how about 8 o'clock if we give a deadline of like 8 o'clock?
Okay,
we can
so if everybody just has their part done by 8 o'clock. You're going to give it to her at 8 o'clock.
Everybody before I do it, or if you guys want to know, you know, if you want to just text me and say mine's ready to go, you know, I'll take my Surface Pro to work tomorrow so that if somebody finishes their part, I'll slip it in and I'll just keep doing it so I'm not trying to do it all at the last minute.
Okay.
Does that work for everybody?
Yeah.
Yeah.
Okay. I think that'll give me enough time too. Like I said, I know my part needs a little work, and I do not work tomorrow, so that will be perfect.
Mm-hmm. Yes.
And
That's
tomorrow,
fine.
if you're done and you text me that it's done and I'm around and I'm not doing anything, I might get on my Surface Pro and I'll stick it into the regular document, the Word document.
Okay.
Okay.
So does everybody feel like they have what they need to finish their part for our meeting on Wednesday?
I think so.
I think so.
I think so. If you guys have any more ideas about if you look at the budget tonight, it's in the Dropbox. If you look at it and you know what, I'll just send this out to you guys, email. If you guys look at it and decide that there's, you know, wait a minute, this sounds stupid, or, you know, can we use this for something else or whatever, I can move money. I'm very good at moving money. I just need to know where to move it.
Okay.
Okay.
Okay. No problem.
Well, I think we had good progress tonight. I feel like we're all on the same page, more so than we have been.
Yes.
It's like we had to get a focus, but I think that a budget forces you to do that because you know, I mean, as I was doing this, when I first had the budget in mind, I was like, oh, we're going to buy this, we're going to buy that, and then they went budget neutral. I'm like, are you kidding me? How are we going to make money? We can't make money doing this kind of stuff.
Okay, and then I have one question before we go off. Do I submit the video? I'm so confused. I'm sorry. I feel like we discussed this last week, and I don't know where that information went.
Yes.
Okay, so I submit the video to
Yes.
the
Yes.
forum,
Huh?
to the Dropbox.
Yeah.
Yeah, to a discussion, whatever board or whatever.
It says Google Hangout thingy on it, doesn't it?
Okay. And then who does the minutes? The scribe?
Yes.
Mhm.
And you will submit them.
I will submit them.
Okay. All right. I just wanted to make sure I wasn't missing anything and not turning something in.
Not accepted.
Like I said, I'm kind of fried, so.
But we made it through that class, you guys. Congratulations.
Yes. Yes.
We're all smart for it, I guess, in one way or another. So
Yeah. One step closer.
Yes.
guys, 8 weeks.
Yes.
Okay.
So our next meeting Wednesday at 7 p.m. with it's the mentor session.
It's gonna be, yeah. Let me just double check. That's Wednesday.
And Lisa, you're gonna do the hangout.
Yep, I'll do the hangout right now.
Are we meeting after after meeting with her?
Yeah.
Or is that our weekly meeting?
You think we could just keep it to the weekly meeting, or do we need an extra?
I'm okay with that.
Me too.
So just on the 1st again are we 6 or 6:30?
Yes, please. Let's verify that.
I have 6:30. I just need to know what time, though. That's for me.
I'm okay with that. I can do 6:30.
Did somebody say 6 at some point?
Well, for some reason, Patricia and I thought 6
Yeah.
6 o'clock.
Our brains are fried. We keep
30.
telling y'all.
So it was like 50-50. We don't know what happened.
Hello. Hey, I saw the little red dot. I just got on. I was like, okay. No,
I'm
no.
good at any time. Anytime you guys want, I'll do.
I'm okay with either one.
Does anybody have a preference?
Nope. I'm good. Whatever
Okay.
you guys decide.
Those
Well,
of you guys with kids, you need to tell us what works for you.
I don't care. Either way, it's a break.
Right. Well, let's shoot for 6. That way, if it goes long or whatever, it's not late.
Right.
Okay.
6 it is.
All right. And so we'll just go over our meeting with her and kind of hash things out next Sunday, but we'll all meet with the mentor on Wednesday.
Yes.
All right. Is everybody good for the evening?
Very good.
Yeah, very good.
All right. Thanks, ladies.
Thank
All right,
you.
bye, guys.
Love working with you guys. Thank you.
Oh, you're welcome.
Have a good
Thank
night,
you.
guys.
Good night.
Good night.